Okay, class, right now what we're going to talk about are lung pathologies. The ones we'll talk about are pneumothorax, atelectasis, pneumonia, obstructive lung diseases, restrictive tuberculosis, and tumors. Let's start first with speaking on the pneumothorax. The pneumothorax basically means air gets into the pleural space. Air gets into the pleural space. Okay. And the way that could occur is basically this. There are two ways. It could be a traumatic one. Now let's go back here. Remember when you look at it, that in the intrapleural space, there's 4 millimeters of mercury pressure less than what's in the lungs, intrapulmonic, and outside here atmospheric. So it's less. If I took 760, which is in the lungs at sea level, of course, at different altitudes, and let that be 0, then 760 would be less than 0, a -4. So some would say that this has a negative pressure. It's not really a negative pressure, but it is less than that's in the lung and out here. Now, in that particular case, if you were the unfortunate recipient of a stab wound between the ribs into the intrapleural space, what would happen? Air out here at 760 would rush in, which would then cause the lungs or a lobe of the lungs to collapse. Doesn't have to be the whole lung, just like you see here. Now, in here you have, let's say, around 150 million alveoli. That's just a number, average number. Now, each of those has a 760. Now, these alveoli are all up in there. Some are on the surface, closer to the surface. Some are up in here. Let's say that you had poor lung tissue and you just popped a few of these alveoli. Realizing that it's 760 up in here, then what would happen? It would rush in there. No trauma. It would just rush in. You just pop it spontaneously and it would do the same thing. That's what we call a spontaneous pneumothorax. You would just be sitting there and all of a sudden lungs would collapse. Okay. What do we do to treat this very quickly? We insert what we call a chest tube. What we do is go between the ribs and insert a tube into the intrapleural space and then hook it to a low suction, water suction called a pneumovac. And what that will do is draw air out and gradually re-expand the lungs, So that's how we do it, by placing a chest tube. Okay, let's go a little further. The next condition we come to is atelectasis. And actually, this piggybacks right on top of what we just did. Atelectasis is when you have a collapse of a lung or a part of the lung. Okay. There are several reasons for atelectasis. One was the pneumothorax we just saw, collapse of the lung. Obstructive, complete bronchial obstruction. Okay, resulting in collapse of parts supplied by the blocked bronchus. Because what would happen is, if you blocked it, then air would eventually diffuse through the tissues, and then the lungs would collapse. Because see, once you lose, think about it, once you lose that residual volume, that peak pressure, you can't keep the airways open. Once you do that, you can't keep the airways open. Surfactant can't do it alone. So eventually it would just collapse. The air's not going to, if you block an area of the lung, the air's not just going to stay in there. It will gradually seep out, even through the lung tissue itself. Okay, that's one reason. Another reason, compression, which should be like the pneumothorax type of thing there. So there's several reasons for it. Okay. But anyway, a collapse of a lung. So when you hear the word atelectasis, that basically means collapse of the lung. Okay. All right, let's go to another condition, pneumonia. Pneumonia is basically an infection of the lung. And what you do is you get this infiltrate, this infiltrate here, inflammation of the lung, pneumonia. So some will call it pneumonitis. The exudate, that's that infiltrate here, spreads unimpeded through the lung, filling the alveoli. That exudate, okay? And the affected becomes relative consolidated, solid, with all this exudative fluid. Okay. At times, the X reaches the pleural surface. This can cause infections, and the different things, the causes can be infectious, chlamydia, virus, and so forth, bacteria. It could involve a whole lung, which we call lobar, or even one lobe lobar, or a bronchopulmonary segment, and that's called a bronchopneumonia. And we take an X-ray. Depends on the difference. You may have heard walk-in pneumonia. That means it's not that bad and we can treat you with oral antibiotics. But if it's considerably bad, then you have to have intravenous antibiotics and other treatments also. All right. You'll get that when you get into a clinical program. Okay. Let's go further. Now I want to talk about right here obstructive lung conditions and restrictive. Okay. The easiest way to diagnose obstructive and restrictive lung conditions is to use the spirometer we talked about. And remember on this, basically what you're doing is that you are breathing in and out. First, on the test, you would breathe in and out and get your tidal volume, which we said it was about 500 cc's. But you remember I mentioned it changes based upon the person and the sex, the race, and everything. That's the title. Then we would ask you to do a vital capacity. Remember, vital capacity is where you'll do some real deep breaths, and then you'll take a deep breath in and blow everything out. That's your vital capacity. What did that include? That included your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume. What did that leave? Your residual volume. And when you do that, this is basically what we're looking at, and the machine is evaluating. Your forced, FEV stands for forced expiratory volume in 1 second. But that's the first second. Then you do, but since you're continuing to blow, you would do, it would calculate the forced expiratory volume in 1 second, then the second second, then the third second. The average person, if they're okay, ought to be able to get everything out in about 3 seconds. Everything out in about 3 seconds. Now, what does that mean? That means if you don't get it out, there's probably some obstruction. If you don't get it out, there's probably some obstruction. Okay? Then we look at the vital capacity itself. See, with a vital capacity problem, which means a volume problem, that generally involves a restrictive condition. So an obstructive condition is the flow rate. But with a restrictive condition, we'll see it has to do with the volume. You don't have as much volume in your lungs. So let's look at what I'm speaking of. Okay. Now, one obstructive lung condition is COPD, chronic obstructive pulmonary condition. Chronic obstructive pulmonary disease involves bronchitis and emphysema. Let's look here. Bronchitis is in the larger airways, and it's inflammation in that area there. Bronchitis is generally in those larger airways, okay? Emphysema is down in the alveoli. It has to do with the tube leading to the alveoli, alveolar duct, the walls getting weak and collapsing. So bronchitis is in the bronchial area with an inflammation in the wall, and emphysema is more of a weakening of the wall down here where air gets trapped. So actually people get a larger lung in both of these. There's not that much of a problem getting air in. It's when you try to get it out, because if these are collapsed, whether down low or up higher, and you try to squeeze the air out, it worsens it, because then it's going to close those areas up higher and this here. So the people generally will get, but here's the deal. If you can't get air out, how you going to get new air in? Okay. So there are various treatments, bronchodilators, all kind of different things that you can talk about in your clinical aspect. But that's what we call COPD, chronic obstructive pulmonary disease. And the two conditions that fall under that are emphysema and bronchitis. Okay. Then we go to asthma. Asthma is more of a reactive airway disease. what it is an inflammation. You can trigger asthma, but you have to have somewhat of a genetic predisposition to trigger that. And then that asthma collapses the airways, undergoes a bronchospasm of these airways. That's why we have to use epinephrine, and the person has inhalers and everything for that. But that's more of a reactive airway disease, where COPD is a continuous type of thing there. Okay? Let's go a little further here. Okay, pulmonary fibrosis gives a reduction in lung volume. So it's a restrictive lung disease. It may be caused by irritant gases. It may be caused by irritation, fibrosis of the lung, which is scarring. There are various reasons for this here. Collagen diseases can do it. So in that case, then the lungs then there's a decrease in compliance. Remember, change in volume over change in pressure, a decrease in compliance. So in this machine, you'd have decreased lung volume than that which is expected. So when you look at that particular aspect, let's come here, you see these normal lungs, and you see these that are all scarred up there. Okay? So that's what you're looking at. Okay, let's go to another one real quickly here. Tuberculosis, you've heard of it. It's caused by the Mycoplasma tuberculum bacillus. There it is. Generally, it starts in the apex. Tuberculosis, it likes a lot of air. The apex has a better flow of air. It has a better, remember V to Q ratio? This has a better ventilation. And so there's a lot of good air up there, and that's where it starts. And then it can increase unless we treat it, and finally cause cavitation and everything. That's what we call fever, night sweats. Night sweats is very characteristic of this. Racking cough, splitting head, and so then we use antibiotics for that. So that's kind of TB. Talked about that. Now, lung cancer, there are three basic types of lung cancer: the squamous cell carcinoma, the adenocarcinoma, and the small cell. Okay, here's kind of a look at those. Okay, the squamous cell carcinoma rises in the bronchial epithelium. You can see here, rises in the bronchial epithelium. The adenocarcinoma originates more in the peripheral areas there. And then the small cell. Now this one, I had a relative to die from this one. Some call it small cell, and under the microscope, those cells look like little oats. So also it's called oat cell carcinoma. And with that, it's very aggressive. Go back to my cancer talk. It's very aggressive. It metastasizes very quickly. Very quickly. So anyway, I just wanted to kind of give you a rundown on a few of the lung pathologies. You can glance at it in your textbook and get an idea, but this just kind of gives you an idea of a few things so you can see how long. But of course, this is just a run through, and of course in your clinical programs, particularly in nursing, and particularly in nursing is where you'll hear more about it and study it far more extensively. I used to teach a pathophys course, but that course was discontinued by the state. So anyway, this kind of gives you an idea. Thank you very kindly.